In this lecture, we are going to discuss something about the hemostasis and coagulation, mostly pertaining to anesthesia, and we will discuss things which are going to have some effect on the anesthesia procedure you are going to do. So, to start with, we have a small quiz-like questions here. They're all true or false, so you can go through these questions and try to answer them, and then you can check your answers in the slide and make sure you have got them, most of them correct. If not correct, please go and revise, and you will get the answers again the second time. The concept of blood coagulation dates back to 1960s when a group of scientists, Davy, Toff, and McLachlan were describing this as a waterfall or a cascade. These theories, they were outlining the fundamental principle of a group or a cascade of proenzymes leading to activation of a downstream enzymes which finally made a clot. Hemostasis is defined as the arrest of bleeding, which comes from the Greek word hem is blood and stasis is to stop. This thrombohemorrhagic balance is maintained in the body by complicated interaction between the coagulation, which is trying to coagulate the blood, and the fibrinolytic system, which is trying, as well as the platelets and vessel walls, which are trying to maintain the normal blood flow immediately after the clot has been formed. This table gives you what are the different parts of the hemolytic system which is taking part in the clotting. So first of all, the site is vessel wall and circulating elements. Then you have the thrombogenic factors, you have the antithrombogenic factors, vessel wall, thrombogenic factors, exposed endothelium, the tissue factor and collagen, whereas the antithrombogenic are heparin and thrombomodulin. So these are the two things we will be taking, and collagen will have the tissue plasminogen activator, the TPA, which are used as anticoagulant also. Circulating are platelets, platelet activating factor, clotting factor, prothrombin, fibrinogen, and von Willebrand's factor. On the other side, the antithrombin will be antithrombin, protein C and protein S, and plasminogen. So this is a very important balance between these two factors of thrombogenic and antithrombogenic, which will keep the circulation clear of clots, and also the clot formation will be immediately available to be bringing the blood back to normal. Primary hemostasis is a complex interaction between platelets, vessel wall, and adhesive proteins, leading to formation of initial platelet plug. Negative charged heparin like glycose aminoglycans will neutral phospholipids, synthesis and secretion of platelet inhibitors, coagulation inhibitors, and fibrinolysis activators get together to initiate this primary hemostasis. Well, in contrast with the subendothelial layer, which is highly thrombogenic and contains collagen, von Willebrand factor, and other proteins like laminin, you have thrombospondin and vitronectin, which are also involved in the platelet adhesion process. Vascular insult results in the arteriolar vasospasm or any blood vessel vasospasm mediated by reflex neurogenic mechanisms and release of local mediators, and also you will see that endothelium and platelet derived thromboxane A2 are also reason for this initiation of the reflex. Okay. Platelets are disc-shaped, enucleate cellular fragments derived from the megakaryocytes. Platelets have two types of granules: alpha granules containing P-selectin, fibronectin, factor 5, factor 8, platelet factor 4, platelet-derived growth factor, and TGF-alpha A, tissue factor alpha. Then you have the D granules or the dense granules containing ATP, ADP, calcium, serotonin, histamine, and epinephrine. So these is the various things in a single platelet which are going to come in different sequences to help the blood to clot. So how it starts first, the platelet adhesion is the first important thing. Vascular injury, the von Willebrand factor act as a bridge between the endothelial collagen and platelet surface receptors and produce the platelet adhesion. The platelet glycoprotein complex is the principal receptor for the von Willebrand's factor. Platelet secretion, the degranulation from both types of the granules takes place with the release of calcium. Calcium binds to the phospholipids that appear secondary to the platelet activation and provide a surface for assembly of various coagulation factors and thus building up of a clot. The platelet aggregation continues with the thromboxane along with the ADP, which enlarge the platelet clot formation, and ADP binding also causes a conformational change in the GP2B and 3A receptors present on the platelet surface, causing deposition of fibrinogen. Thrombin generation also catalyzes the conversion of this fibrinogen to fibrin, which adds to the stability of the platelet plug and is now known as secondary hemostasis. Prostacyclin inhibits platelet aggregation, platelet anti-aggregating effect, and the balance between thromboxane A2 and prostacyclin leads to localized platelet aggregation, thus preventing extension of the clot, thereby maintaining the vessel wall, lumen patency, and continuation of the blood flow after the clot has formed. This table gives you the bird's eye view of primary hemostasis. So usually bleeding disorders due to vessel wall abnormality, septicemia, drug reactions, scurvy, and Ehlers-Danlos syndrome, Hanoch-Sanchin purpura. So there are a lot of these primary causes for bleeding, and also the disorders lead to unnecessary problems during anesthesia also. Now we are more concerned of blood transfusions. 90% of the blood transfusions are done during operative period, and most of them are handled by the anesthesiologist. So massive blood transfusion entails the replacement of one whole blood volume within a period of 24 hours. And also remember that stored blood is deficient of both the functional platelets and coagulation factors, as it is a packed RBCs. Transfused red blood cells dilute the patient's native coagulation reserve also. When you give a massive transfusion, all the coagulation factors within the patient also are diluted. You should also take care that fluids will dilute them more, particularly if you are using colloids, and massive transfusion may lead to DIC and coagulation, the dilutional coagulopathy. Take care, and you should always maintain all the coagulation factors along with the blood the packed RBCs you are giving. So the coagulation pathways, the proteins are the core component of the coagulation system that lead to a complex interplay of reactions resulting in the conversion of soluble fibrinogen to insoluble fibrin bands. Procoagulants and anticoagulants are produced by the liver except for factor 3, 4, and 8. These proteins undergo a post-translational modification, that is the vitamin K dependent gamma carboxylation, which enables them to bind calcium and other divalent cations and participate in the clotting cascade. Deficiency of vitamin K or administration of vitamin K antagonists like warfarin leads to anticoagulation. Nomenclature of these coagulation proteins is rather complex. The first four of the 12 originally identified factors are referred to by their common names, that is fibrinogen, prothrombin, tissue factor, and calcium, and are not assigned by any Roman numerals. The factor 6 no longer exists. The more recently discovered clotting factors, the prekallikrein and high molecular weight kininogen, have not been assigned Roman numerals. Some factors have more than one name, so factors 5 and factor 7, factor 5 and factor 8 are also referred to as the labile factor because their coagulation activity is not durable in the stored blood. So this is the description of all the clotting factors along with the numbers. So you can go through this, and also remember that you may have to just remember a few of them which are important. The others are just for reference. So please try to understand how they are used and where they are and what is at least a few of their plasma level concentrations. When you are practicing blood transfusion, you may have to check these things, particularly when they are present as a report or a result. Prothrombin is a plasma protein formed by the liver with a molecular weight of 68,700. Unstable protein splitting into smaller proteins, one of which is the thrombin. So that molecular weight is almost half of it, 33,700. Thrombin generated from prothrombin also has pro-inflammatory effects which are exerted by the activation of protease activating receptors present on the monocytes, lymphocytes, endothelium, and the dendritic cells. Von Willebrand factor is a glycoprotein present in blood plasma and produced constitutively as ultra-large von Willebrand factor in endothelium, megakaryocytes, and subendothelial connective tissue. It mediates platelet addition to subendothelial surface. It also acts as a carrier protein for the coagulant activity of factor 8 and is referred to as factor 8C. Fibrinogen and factor 3, which is the tissue factor. Fibrinogen is an essential coagulation protein produced by the liver with a molecular weight of 340 kilodaltons and is a precursor of fibrin that ultimately defines the strength of the clot. Factor 3 or the tissue factor is membrane-bound procoagulant glycoprotein with a molecular weight of 47 kilodaltons present in the subendothelial tissue and fibroblasts and is not exposed to blood until disruption of the vessel wall occurs. It is the primary initiator of coagulation in vivo. Tissue factor is localized predominantly to the tunica media and tunica adventitia of the blood vessels, and a smaller quantity is circulating on the monocytes. Clotting factors can be also classified into three groups: fibrinogen family, vitamin K dependent proteins, and contact family. So this is how they are divided. The fibrinogen family has fibrinogen, factor 5, factor 8, factor 13, whereas the vitamin K dependent factor 2, factor 7, factor 9, and factor 10, and the contact family factor 11, factor 12, high molecular weight kallikreins, and prekallikrein. Coagulation cascade has been traditionally classified into external and internal and intrinsic and extrinsic pathways, both of which cover on converge on factor 10A. So this is the chart showing you the intrinsic pathway and the extrinsic pathway and the common pathway, which was the earlier concept. Now the slide, the figures below in the slide are now the concept of the present day. So this is the current concept. You can see here tissue factor is in damaged blood vessels, which binds to factor 7A to activate factor 9 and factor 10. This activation of factor 9 by the tissue factor 7A complex serves as a bridge between classical extrinsic and intrinsic pathway. Factor 10A then binds to factor 2 to form the thrombin, and thrombin generation through this reaction is not robust and can be effectively terminated by tissue factor pathway inhibitor. Now the second step is the amplification. Amount of thrombin generated is not sufficient. Numerous positive feedback loops are present that bind thrombin with the platelets. Thrombin that is generated in the initiation phase further activates factor 5 and factor 7, which serve as a cofactor in prothrombinase complex and accelerate the activation of factor 2 by factor 10A and of 10A to factor 9A. The accumulated enzymes continue with the coagulation cascade and propagate, and these enzymes are on platelet surface support robust amount of thrombin generation and platelet activation. To ensure continuous generation of thrombin and subsequent fibrin to form a sufficient large clot, the process to continue in the same way to increase the clot. Now the stabilization consists of thrombin generation, which leads to activation of factor 13, which is fibrin stabilization factor, which covalently links fibrin polymers and provides strength and stability to the fibrin incorporated in the platelet plugs. In addition, thrombin activates thrombin activatable fibrinolysis inhibiting factor that protects the clot from fibrinolysis initially. Disorders of the coagulation: a balance between the clotting and the bleeding is always maintained in the body under normal physiology. Any pathological scenario will tilt the balance to either hemorrhagic or thrombotic complications. Disorders of hemostasis can be categorized into that lead to abnormal bleeding and those that lead to abnormal clotting. So these are the disorders of coagulation with the bleeding disorders and the thrombotic disorders. 1 Williams disease, hemophilia A, B, C, factor 5 deficiency, factor 10 deficiency, factor 7 deficiency, factor 13 deficiency. All these are bleeding disorders. With the other side, you have hereditary thrombophilia, antithrombin 3 deficiency, you have the protein C deficiency, protein S deficiency. So in your practice, you will come across a few of them, particularly hemophilia A and protein S and protein C deficiency on either side of the classification. The bleeding disorders, most of the, as I told you, the most common is the hemophilias, is associated deficiency of factors 8 and B, that is Christmas disease, is secondary to deficiency of factor 9. So C is only found in 1% of the population due to deficiency of the factor 11. 10 is not involved here. The X-linked recessive disorders occur in males. The severity of the bleeding tendency is directly related to the levels of the coagulation factors. The levels of factor 8 need to be assessed in the preoperative period, and human or recombinant factor 8 concentrations are transfused to keep the factor 8 levels 100% in the preoperative and the perioperative period to reduce the bleeding. 1 Williams disease, the most common autosomal dominant inherited disorder of coagulation due to abnormality in the production of 1 Williams factor, which may be qualitative or quantitative. The clinical presentation may be variable, and complete deficiency, though rare, leads to severe bleeding. The diagnosis is usually made by prolonged bleeding time in the presence of adequate platelets. Fibrinolytic agents and tranexamic acid may be used for minor bleeding. Desmopressin, D-arginine vasopressin administered in the preoperative period is expected to raise the concentration of factor VIII in patients with quantitative disorders. Then next one is the fibrinogen deficiency. Total or partial is extremely rare inherited bleeding disorder. Afibrinogenemia is rather well tolerated and may manifest as subcutaneous hematoma or umbilical hematoma at birth. The clinical findings are variable in childhood and adults. DIC is the most common consumptive coagulopathy that may be observed secondary to numerous causes. Common causes of fibrinogen deficiency are sepsis, infections, obstetric causes, incompatible blood transfusions, shock, trauma, embolism. Liver diseases also are a contribution to the bleeding disorders. Majority of the clotting factors are synthesized in the liver. Therefore, severe liver disease is associated with coagulopathy. Since liver is also involved in the clearance of activated clotting factors and fibrinolytic products, it may predispose to disseminated intravascular coagulation. Management of bleeding secondary to liver disease is based on the laboratory values of various coagulating tests. Associated with anesthesia is hypothermia. So you should take care that anticoagulatory effects, which are more pronounced in the presence of acidosis, along with hypothermia, is the main cause for bleeding disorders during anesthesia. The effect may result from platelet dysfunction in mild hypothermia, even below 35 degrees centigrade, to decrease synthesis of enzymes and plasminogen activator factors when the temperature drops below 33 degrees centigrade. So maintaining the body temperature of the patient during the anesthesia is very, very important. Oral anticoagulants are available, and particularly the newer ones like the dabigatran, etioxylate, or factor 10A inhibitors, that is the rivaroxaban or apixaban, when they also have advantage of a rapid onset and offset and minimal drug interaction with more predictable pharmacokinetics, thus eliminating the need for frequent coagulation monitoring in patients. All these features give newer oral anticoagulants a major pharmacological benefit over the vitamin K antagonists like warfarin. Thrombotic disorders, plasma concentration of certain coagulation factors, factor 5, factor 7, factor 8, factor 9, fibrinogen, van Willebrand's factor, increase as age increases. High incidence of cardiovascular events are seen in elderly, maybe due to the increased level of plasma fibrinogen. Enhance the bridging of the platelet via glycoprotein 2B to 3A receptors and act as a direct substrate for clot and or by increasing the blood viscosity. Hypercoagulable states, there are a number of factors that are associated with the hypercoagulable states. The genetic and hereditary disorders that predispose to thrombosis, several risk factors such as smoking, obesity, pregnancy, immobility, malignancy, surgery, females on oral contraceptives, disorders of AT3 deficiency, reduced protein C and protein S are inherited in autosomal dominant fashion and are associated with increased risk of thrombosis. Acquired protein C and protein S deficiency may be observed in vitamin K deficiency, warfarin therapy, pregnancy, liver cirrhosis, and sepsis. So the effects of surgery and anesthesia on coagulation, thromboembolism in the perioperative period is well recognized. Therefore, patients with hereditary thrombophilia should be given thromboprophylaxis. During pregnancy, stasis due to the obstruction of the inferior vena cava by gravid uterus, along with increase in the majority of clotting factors and fibrinogen and van Willebrand factor are observed. Activity of protein S decreases with simultaneous resistance to protein C. In addition, fibrinolytic system is also impaired, thus contributing to a hypercoagulable state that makes the parturient more prone to thromboembolism. Surgical trauma, prolonged immobility promotes stasis, which results in local hypoxemia. Physical disruption leads to exposure of tissue factor, thus triggering thrombosis. During the first hours of surgery, there is an increase in tissue factor, tissue plasminogen activator, and 1 Willebrand factor leading to a hypercoagulable state. Even a venipuncture can cause vascular wall injury, thus predisposing to thrombus formation. Venipuncture is preferably avoided in the lower limbs. We have different factors and how we can use them and how we can check them during our process of anesthesia. Platelet count, automated counting, cannot detect the presence of small or extremely large platelets. Manual smear can exclude the presence of pseudothrombocytopenia and due to in vitro platelet agglutination. Bleeding time is very important. It is a bedside test. You can evaluate the platelet vascular endothelium interaction. Prolonged bleeding time may occur in thrombocytopenia if it is less than 50,000 platelets, and qualitative platelet abnormality, example in uremia, 1 Willebrand fracture disease, and also you may have it in fibrinogen deficiency. Does not predict any surgical bleeding and is limited usefulness in clinical bleeding disorders. Prothrombin time, that is the PT, which we regularly order for, measures the efficiency of the fibrin production through the extrinsic pathway and the final common pathway. Tissue factor, factor 7, that is within the extrinsic pathway, and factors 10, 5 prothrombin, and also the fibrinogen. Factors 7, 10, and prothrombin are dependent on vitamin K and affected by the comedines, that is particularly the warfarin, and therefore PT is used to monitor anticoagulation with warfarin. International normalized ratio, that is INR, compensates for differences in the PT reagents, and INR is equal to patient PT over the control PT, patient's prothrombin time versus the control prothrombin time. Activated partial thromboplastin time, that is the APTT, measures the intrinsic factors, factor 12, factor 11, factor 9, and factor 8, and common pathway, factor 2, factor 5, factor 10, and fibrinogen, used to monitor heparin effect and to evaluate deficiencies of all coagulation factors except for factor 7 and factor 13. Thrombin time measures the time it takes for a clot to form in the plasma of a blood sample of which an excess of thrombin has been added. If a patient is receiving heparin, a substance derived from snake venom called reptilase, not inhibited by heparin, is used instead of thrombin. Normal thrombin time is 10 to 15 seconds or within 5 seconds of the control. Normal reptilase time is between 15 to 20 seconds also, and the thrombin time can be prolonged by heparin, fibrin degradation products, factor 13 deficiency, and fibrinogen deficiency or abnormality. The activated clotting time, the ACT, and activated against Calila or choline, which is added to the blood and the sample. The time to form the clot is measured. Used to confirm and monitor heparin effects as a point of care test during cardiac or vascular surgery, and a proper amount of protamine can be calculated by the calculation of ACT. The latest and the best of them is the thromboelastography, which measures the clinical clot formation and lysis not specific to the coagulation pathways. Thromboelastogram reflects clinically significant hemostasis and can guide transfusion of factors and platelets. coagulation is activated by adding calcium to a sample. Perioperative management of patients with coagulation disorders is a very important thing for the anesthesiologist to understand, because he may face a situation like this and may have to balance the clotting as well as the bleeding during the surgery. So, are divided into disorders of hemostasis and disorders of thrombosis. Hemophilia A is the most common of the hemophilias and associated with the deficiency of factors 8 coagulant proteins. Hemophilia B, the Christmas disease, is caused by deficiency of factor 9 coagulation proteins. So this is the hemophilias and how they are treated. So you can go through. So most important is the factor 8, which is very, very important, and you have to keep it 100% to the level of 20 to 50 international units per ml to keep the coagulation normal. Plasma levels of factor 8 to achieve hemostasis. So early hemostasis or muscle bleeding 15 to 20. So dose of factor 8 in international unit per kg will be 8 to 10. Minor trauma or more severe bleeding, you want to maintain the international unit of plasma factor 8 to around 30 to 50, and you will have to transfuse 15 to 25 international units per kg. And surgery with major trauma or head injury, you may have to maintain between 80 to 120. So you will transfuse a dose of factor 8 of 40 to 60 international units per kg. Acquired disorders of hemostasis, consumptive coagulopathies, particularly a spectrum of disorders characterized by inappropriate and widespread small vessel thrombosis associated with generalized bleeding as a result of consumption of the coagulation factors and excessive fibrinolysis. So where the coagulation factors are consumed very fast. DIC is the most common consumptive coagulopathy, often with a prodromal thrombocytopenia giving way to hyperfibrinogenemia as a result of excessive fibrinolysis, and latter demonstrated by increased fibrinogen degradation products and D-dimer. So this is the DIC and thrombocytopenia. In the chart is comparing the two factors which are going to occur. Perioperative management of patients on anticoagulation is very, very important for us, because most of the patients in the recent times are on one or other type of anticoagulant for their diseases. So interruption of therapy can increase the risk of thrombotic events during and after the surgery, and non-interruption of these medications can heighten the chances of bleeding during the surgery and trigger sequences of problems which are can be avoided by proper planning. Anticoagulation therapy is most commonly indicated in the presence of atrial fibrillation, deep vein thrombosis, pulmonary embolism, after placement of prosthetic heart valves, and patients have undergone PCI are typically on dual antithrombotic therapy, and patients with a past medical history of stroke, coronary artery bypass graft, and essential thrombocytosis could require antithrombotic therapy. So the most common drugs of them is aspirin. Its mechanism of action is irreversible. Remember, it is irreversible inhibition of cyclooxygenase, COX-1 and COX-2 enzyme. The action of COX is necessary for the conversion of arachidonic acid to prostaglandin, and prostaglandin H2 is rapidly converted to several bioactive prostanoids, including thromboxane A2, a potent vasoconstrictor and an inductor of platelet aggregation. Despite the short half-life of aspirin, 3 to 6 hours, its irreversible effect lasts for complete lifetime of the platelet, which is usually 8 to 9 days. The NSAIDs are inhibiting the COX enzyme again, depending on the drug. We have now specific COX enzyme inhibitors. Some NSAID they will inhibit the COX-2 enzyme and mediate pain and inflammation, simultaneously inhibiting the undesirable effects of COX-1 inhibition. The effect of NSAID on platelet function is considered a short-term effect that normalizes within 3 days, Nonetheless, this can vary according to the drug class. Short-acting drugs like ibuprofen, diclofenac, and indomethacin, 50% of the platelet function is restored back in 6 hours after the last dose, and normalization usually occurs within 24 hours. Thienopyridines, the clopidogrel and prasugrel, these are the drugs which are inhibitors of adenosine diphosphate receptors, also called as P2Y12 receptor inhibitors. Okay. Physiologically, the union of adenosine diphosphate with its receptor increases intracellular calcium level and activates the GP2B and 3A platelet receptor that promote the stabilization of the platelet clot through fibrinogen bonds. Clopidogrel and prasugrel are prodrugs in which active metabolites irreversibly affect the platelet function in a time and dose dependent fashion. A clopidogrel dose of 75 mg daily produced at 60% decreased in platelet function in 3 to 5 days. In contrast, a 600 mg loading dose can achieve a steady state of platelet inhibition within 6 to 8 hours. In the same way, loading dose of prasugrel of 60 mg is enough to produce steady state platelet inhibition 2 hours after drug administered. Due to the irreversible mechanism of action, it is recommended to interrupt the dose or the drug 5 to 7 days before non-cardiac elective surgery to reduce the bleeding. Non-thienopyridine drugs, ticagrelor is a reversible, non-competitive ATP analog that binds to a G protein in the P2Y12 receptor, preventing its activation and signaling. After a loading dose of ticagrelor, the maximum antiplatelet effect is achieved within 2 hours. Plasma half-life 8 to 12 hours and steady state concentration in 2 days to 3 days. Due to the reversible effect of this drug on platelets, it is recommended to be suspended 5 days before surgery. Cangrelor is a direct, reversible, and intravenously administered drug that inhibits the P2Y12 receptor. Cangrelor can inhibit 95 to 100% of platelet activity within the first 2 minutes of administration. The plasma half-life is 3 to 6 minutes, allows the recovery of 80 to 90% of platelet function within 60 to 90 minutes of discontinuing the intravenous infusion. So it is a very good drug for quick onset and quick offset for the patients who are needing anticoagulation during their surgery. The vitamin K antagonists, particularly warfarin, these are also called coumarins. The most recognized and widely used drug of this group is warfarin, which has been available for the last more than 50 years. The mechanism of action of warfarin is inhibits the 2,3-epoxide reductase enzyme responsible for cyclical conversion of oxidized vitamin K in a reduced state. The latter is necessary as a cofactor for the carboxylation of glutamic acid at the N-teradienines of coagulation factors. Clotting factor 2, 7, 9 and 10 cannot bind to the divalent calcium necessary for normal activation without gamma carboxyglutamic acid reductase. Warfarin is a racemic mixture of R and S stereoisomers of the drug, and the S isomer is 3 to 5 times more potent than the R isomer. The half-life of warfarin is 36 to 42 hours. S isomer is 29 hours, R isomer is 45 hours. Nonetheless, it can be altered by several factors. In practice, warfarin is a drug of difficult titration due to the high number of pharmacological interactions, and genetic variations that can affect in the daily use. Direct inhibitors of factor 10A, these are the newer drugs, rivaroxaban, apixaban, endoxaban, and betrixaban. The common mechanism of action of these drugs is also known as direct oral anticoagulation or DOACs, is to bind to the active site of factor 10A, thus inactivating it. Factor 10A is considered the rate limiting step for the progression of the coagulation cascade, thrombin activation, and ultimately clot formation. Advantages of prescribing these drugs is their short half-life and rapid onset of action, allowing for an easier interruption and re-initiation of anticoagulation therapy after surgery. Direct inhibitors of factor 10A have a low risk of bleeding compared to the vitamin K anticoagulants, making routine coagulation less unnecessary for these drugs. However, pharmacokinetic properties of each of these drugs can vary according to the renal and liver function, and this is being shown in the chart here. Dabigatran is the only medication in this group of the direct inhibitors of thrombin. Its mechanism of action is the direct inhibition of thrombin, preventing the conversion of fibrinogen to fibrin and thus clot formation. Dabigatran has a quick onset of action, 0.5 to 2 hours, and is metabolized by non-specific plasma esterases. The plasma half-life is around 12 hours. However, the half-life of drug is tremendously affected by the renal excretion, as 80% of the drug is excreted by the kidneys and less than 10% by the liver. It is recommended to avoid dabigatran use with creatinine clearance less than 30 ml per minute due to the potential for drug to accumulate and the adverse effect of causing bleeding. Fondaparinux was very commonly used before the introduction of these oral acting drugs. So this drug is a pentasaccharide that acts as an indirect factor 10 inhibitor. The exact mechanism of action is reversible binding of the drug to antithrombin factor, potentiating its activity to inactivate factor 10A. The plasma half-life of fondaparinux is approximately 15 to 17 hours. Its anticoagulant properties persist even 2 to 4 days after the last dose of the drug in a person with normal renal function. Heparins of the heparin molecule binds to the antithrombin 3 receptor and hence its capacity to inactivate factor 7 and factor 10A. One of this pharmacological group's most concerning adverse effects is possibility of heparin-induced thrombocytopenia. We call it HIT, usually causing the heparin to be useless in few patients. In patients with renal failure and creatinine clearance of less than 30 ml per minute, low molecular weight heparin should be avoided or adjusted according to the renal function. The use of unfractionated heparin is a suitable option in this case. Heparin can be administered as a therapeutic dose for patients with high thromboembolic risk, enoxaparin 1 mg per kg twice daily or dalteparin 100 units per kg twice daily, or as a prophylactic dose of patients undergoing bridge therapy, enoxaparin 40 mg once daily or dalteparin 5000 units once daily. How do you evaluate the patient who is on antithrombotic therapy? The approach recommended by several guidelines is based on 4 considerations. First, determine the thromboembolic risk of the patient. Then determine the procedural bleeding risk. Then determine whether or not the interruption of anticoagulation antithrombotic therapy will affect the patient. Clinical judgment is imperative as there is no score or calculator to determine the classification of these patients straightforwardly. So you should know what are the different surgeries which lead to risk of bleeding. We have low risk bleeding procedures or surgical procedures and high risk surgical procedures which can cause bleeding. So in the low risk, minor dental procedures, extraction, endodontics, restoration, prosthetics, cataract removal, joint injections, diagnostic endoscopy, laparoscopic cholecystectomy, and further on. In the high risk, colonic polyp resection, ERCP with sphincterotomy, surgery in high vascularized organs like liver, kidney, spleen, cardiac surgery, intracranial surgery, spinal, major orthopedic surgery, plastic surgery, reconstructive, and any other surgery which goes more than 4 hours. So the timing for the DOC interruption before surgery, you can go through this chart and make yourself very thorough with this. You have to stop the drug as recommended by this chart and also restart also by the recommendations of these charts. Let's take a case scenario. Common scenario is a patient with coronary stents, most of which are on dual anti-aggregation drugs. Approximately 5% of these patients require surgery during the next year after coronary stent implantation. Suppose aspirin and thienopyridine need to be suspended during the perioperative period. In that case, the elective surgical procedure should be delayed 6 weeks at least for patients with bare stents and 6 months for drug-eluting stents patients. In case the elective surgery cannot be postponed, the dual anti-aggregation therapy should be continued throughout the perioperative period with controlling the bleeding if it occurs. During the perioperative period, discontinue warfarin 5 days before surgery. 3 days before surgery, start subcutaneous low molecular weight heparin or unfractionated heparin at therapeutic doses depending on the patient's renal function. 2 days before surgery, assess the INR. If it is greater than 1.5, vitamin K can be administered at a dose of 1 to 2 milligram. Discontinue the low molecular weight heparin 24 hours before surgery or 4 to 6 hours before surgery of the unfractionated heparin. So these are very important guidelines. You have to make sure this is bridging of the anticoagulation during the procedure itself. During the postoperative period, if the patient is tolerating oral intake, there are no unexpected surgical issues or bleeding and would increase the bleeding risk, restart warfarin 12 to 24 hours after surgery. If patient received preoperative bridging therapy, high thromboembolic risk, and underwent a minor surgical procedure, resume the low molecular weight heparin or the unfractionated heparin 24 hours after surgery. If the patient underwent a major surgical procedure, resume the low molecular weight heparin or the unfractionated heparin 48 to 72 hours after surgery. Always assess the bleeding and also adequacy of hemostasis before resumption of the heparin itself. So again the same chart just to make sure that you understand it clearly. So it depends on the renal function and you should be judiciously using this drug according to the creatinine clearance. Consideration of the patients undergoing neuraxial anesthesia like spinal, epidural, timelines of interrupting and resuming anticoagulation after puncture, catheter manipulation or removal should be strictly followed. Patient treated with intravenous unfractionated hemoglobin, heparin, the infusion should be interrupted 4 to 6 hours before puncture or catheter removal or manipulation. If the patient received unfractionated heparin subcutaneously, the patient should not be manipulated with the epidural or the removal or the inserts of catheter 8 to 12 hours in the time frame. Independent of the route of the unfractionated heparins, the drug can be restarted 1 hour after the puncture or the catheter removal or manipulation. So you can give a gap of 1 hour before manipulating again. In case of a prophylactic dose of low molecular weight heparin, the drug should be stopped 12 hours before puncture of the catheter removal, catheter manipulation, catheter insertion. 24 hours if the dose is therapeutic. Independent of the low molecular weight heparin dose, the drug may be restarted 4 hours after the puncture or catheter removal or the manipulation of the catheter. Patient receives fondoxaparin at a prophylactic dose 2.5 mg per kg. It should be stopped 36 to 42 hours before any neuroaxial approach is done and resumed 6 to 12 hours after the procedure. Patient on rivaroxaban at a prophylactic dose less than 10 mg per kg should have the drug interrupted 22 to 26 hours before the neuroaxial approach. If the patient is on apixaban at a prophylactic dose, it should be discontinued 26 to 30 hours before the neuroaxial puncture or catheter replacement. Both of these drugs can be started 4 to 6 hours after the procedure, that is the puncture for the catheter or removal or manipulation. If the patient is on coumarin anticoagulants, the INR should be less than 1.4 before any neuroaxial approach is done. Drugs such as the non-steroidal anti-inflammatory including aspirin do not require interruption of neuroaxial anesthetic interventions. Others such as clocylostazole require 42 hours of an interruption before the neuroaxial anesthesia can be resumed after 5 hours after the puncture catheter removal. Now, if you have urgent need to reverse the anticoagulation, usually it is defined as that it cannot be delayed more than 24 hours, giving time to the physician to conduct the anticoagulation reversal based on repeated coagulation tests. Emergent scenario can be defined as one which the patient requires surgical intervention in less than 1 hour of experiencing life-threatening bleeding. So this is a way to do it. If INR is 2 to 4, you will give a prothrombin complex concentrate of 25 international units per kg. If the INR is more than 4 to 6, you will give a 35 international units per kg dose. If it is more than 6, you will give a 50 international unit per kg dose. And vitamin K also 10 milligram IV administered slowly, and fresh frozen plasma 10 to 20 ml per kg. Trauma patients also add on 1 gram of tranexamic acid and used at arrival and a repeat dose of 1 gram after 8 hours. The PCC is commercially available as a prothrombin complex concentrate that contains heparin and is thus contraindicated in patients with a history of heparin-induced thrombocytopenia. Patients should not use this drug. So anticoagulation reversal agent for patients on the oral drugs. So you can go through this chart and check what are the things we are trying to manipulate in a patient who has these things. So recommendation: assessment of hemostasis in the preoperative period can reduce perioperative blood loss. Red cell concentrates do not contain coagulation factors or platelets, so the use of blood components, fresh frozen plasma, platelets need to be considered early in the management of a patient who needs a massive transfusion or a massive hemorrhage has occurred. Emergency use of blood components require assessment of hemostasis in advance of administration, even if empirical use is necessary. The use of near-patient testing devices can improve decision making on the use of blood components. Thawed FFP can be stored at 4 degrees centigrade and can be used safely within 24 hours. Thawed FFP kept at room temperature must be infused within 4 hours so that we don't waste the very important things. Vitamin K prothrombin complex concentrate is recommended to reverse warfarin effect. FFP is indicated when there is severe bleeding or when PCC is not available. Platelet transfusion in the bleeding patient or a patient requiring urgent surgery is indicated at a platelet count of less than 50,000. Component therapy should be used to make regional anesthesia possible if there are alternative anesthetic methods are available. So with this we come to the end of the slideshow. Hope you have understood. Please go through and make yourself more well versed by studying it as much as possible. Thank you very much.